Okay, good afternoon. Is my audio clear?
Yes, sir.
Okay, sige. So for this finals period, again, we will be dealing with the different disorders affecting RBCs and WBCs. So we'll have the first two meetings ngayon at saka next week with RBC disorders, and then the following next meetings, yan, will be allotted for WBC disorders, and particularly with leukemia. Okay, so if you have any questions or clarifications, type nyo na lang sa chat box. Okay? O for a while ha. Okay, so for this finals period in Hema1, it would be about diseases affecting RBCs and WBCs. So basically, for these finals, we will be dealing with anemia and leukemia. Okay, so for the first portion of the diseases affecting red cells for today, we'll have anemia. Okay, so we'll have it in two sessions. So for today, we'll have the first part of anemia, and then next week, you'll have the second part. Okay, so if you have any questions or clarifications, then feel free to send me an email or message me on our Canvas or in our Google Classroom. Okay? So, for RBC disorders, basically, our main concern would be about anemia. Okay? So, most of you will think of na when we say anemia, sir, there's less red cells. Right? 'Di ba? In Tagalog yung ah, mga medyo nakakatanda nating magulang or kung sino man, 'di ba? They will tell us when you say anemia, ito yung sakit sa pulang dugo, right? Pulang dugo, which refers to technically RBCs, right? So, generally speaking, when we say anemia, there's a problem with RBCs. Okay? There's a problem with the ability of red cells to deliver oxygen. Remember, the main function of our red cells in the body is to deliver oxygen. Tama? And red cells are able to do so because red cells have hemoglobin inside. Right? So, when you say anemia, remember, it's whenever there's a reduction in red cells mass. Red cells mass, which is referring to your hemoglobin content. So meaning to say, if you go with the laboratory setting, if you want to screen or identify persons with anemia or at risk for anemia, the first parameter or the first test that you need to check would be hemoglobin. Okay? Kasi hindi porket mababa ang RBC count, let's say, automatic mababa na rin yung hemoglobin. Okay? So if you want to screen or identify individuals at risk for anemia, the first parameter you should check is hemoglobin. So if hemoglobin is down, then that gives you an idea that your patient has anemia. And you suspect that there's anemia if your hemoglobin value is less than 12 grams per DL. So let's say nag-measure ka ng hemoglobin and it happens to be less than 12 grams per DL, then you will then already suspect it as anemia. Okay? And anemia could be of two things. Anemia could be relative or absolute. When you say relative, remember, it is something temporary. Okay? It is something transient. Kasi look at the description. When you say relative anemia, red cells mass is normal. So meaning to say, pwedeng normal naman yung hemoglobin content natin, but your blood volume is low. Okay? So let's say possibly you are dehydrated. Okay? Dehydrated ka, so kulang ka ng water. Remember, majority of our plasma, of our blood, is made up of water. Tama? So this water will allow free circulation of red cells to deliver oxygen onto our tissues. So, even if your red cells have normal mass, have normal hemoglobin content, but the amount of blood, the amount of water, let's say, circulating within your body is low, still, you may end up with less delivery of oxygen to your tissues. Do not forget that. When you talk about anemia, our main concern will always be the delivery of oxygen to the tissues. Bumababa yung ability ng katawan natin to deliver oxygen onto our tissues. Okay? But then, when you say relative, it's something temporary lang. So let's say if you are dehydrated right now, then later on, you supplied back water in your body, then expect that slowly by slowly, your anemia will be corrected. Okay? That's the thing with relative anemia. Kaya 'di ba, if you're dehydrated, 'di ba, you look pale. 'Di ba? Namumutla ka, nawawalan ka ng energy, nawawalan ka ng lakas. It's because there is less delivery of oxygen onto your tissues. Okay? And then when you say absolute, meaning to say, it's a true anemia. Okay? True anemia. You look at the description. There's low red cell mass and normal plasma volume, normal blood volume. Okay? Meaning to say, your problem really deals with RBCs. Okay? And this absolute anemia could be of these two things. Low RBC delivery into the circulation or loss of RBC from the circulation. Okay, let's differentiate that. Okay? So when you say low RBC delivery to the circulation, that means your problem is production. Meaning to say, there could be a problem in your bone marrow. That's why you fail to synthesize enough amount of RBCs. Kaya on your circulation, there's low level of RBCs. Your RBC count is low. Okay? Then, when you say loss of RBC from the circulation, let's say, sir, my bone marrow was able to synthesize red cells. It's just that, on my blood, sir, on my circulation, sir, there are things or there are factors that destroyed my RBCs. O say, for example, you are infected with a parasite. Let's say, for example, Plasmodium falciparum. So because of that, your red cells have been lysed. Your red cells have been damaged. And because of that, less red cells will then circulate in your body. Okay? So pag sinabi natin absolute anemia, the problem really lies with your RBCs. So it's either you fail to produce them, or let's say you are destroying the red cells, or let's say you really have problems with the synthesis of hemoglobin. Let's say, sir, kasi kulang ako ng iron. Sir, kasi kulang ako ng folic acid, ng vitamin B12. So that still falls under absolute anemia. Okay? So do not forget that. Relative is something temporary, and absolute means the problem deals with the red cells themselves. Okay? And a person with anemia may then experience the following signs and symptoms. So obviously, there could be difficulty on breathing, dyspnea, mabilis kang mapagod, there could be palpitations. Palpitations because since there's less distribution or delivery of oxygen to your tissues, it's like it will send signals to your heart to work faster. Okay? To work harder. Kaya there could be some sort of palpitations. Okay? So there could be pallor, faintness, vertigo, headache, and even spooning nails. Spooning nails, parang isipin nyo, yung nails nyo is parang yung shape ng club shape that resembles a spoon. Diba? If you will look at your nails right now, diba, parang pag tinignan mo siya side view, parang may pagka-flat naman siya. Right? It's a bit curved, pero it's technically flat. Pero kapag spooning nails, then it's the curvature on your nails are very obvious. Okay? So a person with anemia may experience the following. And what's important at the end of the day, being medtechs, would be the different tests that will further evaluate anemia. Okay? So as medtechs, definitely this would be our concern. And again, the first parameter that we should check if we want to screen individuals, check individuals suspected with anemia, would be your hemoglobin. Okay? Sir, is my red cell count helpful? Yes, still it's helpful. Kasi there are forms of anemia wherein normal yung hemoglobin mo, pero the number of red cells is low. That's why you suffer from anemia. Okay? You have here your red cell indices, your MCV, MCH, and MCHC, so that later on, we can classify types of anemia. We have RDW, if you can recall it. This will then tell us the degree of anisocytosis. It will tell us how much red cells vary in size and vary in shape. Right? PBS refers to peripheral blood smear. Okay? So this would then be used for the qualitative description of the appearance of blood cells. So you can then check here, confirm here the size, the color, the shape, maturity of cells. Kasi remember, as what we have explained nung sa hematologic test, blood smear, remember, gives us a picture of the true condition of blood. Whatever size, whatever shape, whatever appearance of our cells are, it can only be pictured out, we can only examine it if you will be using a blood smear. Okay? And then, osmotic fragility test here, if you will recall it, evaluates the relationship of red cells surface area to its volume. Diba, in the osmotic fragility test, we are testing how capable our red cells are in preventing lysis. Right? How capable our red cells are in protecting themselves against lysis. And we make use of osmotic fragility test so we can then later on identify abnormalities like hereditary spherocytosis. Right? Reticulocyte count, as what you've learned, it is used to assess the erythropoietic activities of the bone marrow. Right? It's like, this is the index of RBC production. So if you have anemia right now and your bone marrow, your reticulocyte count is normal or higher, then that tells us na your bone marrow is responding. Okay? Your bone marrow is capable of producing RBCs. Okay? Remember, retics serve as an index of RBC production, especially in cases of anemia. Okay? Then definitely, when all is said and done, remember, you will never go wrong with the examination of your bone marrow. Especially if your problem deals with the number of circulating RBCs. If the number of red cells are high or are low, then you can always check your bone marrow. Bakit? For a very simple reason. RBCs are synthesized from your bone marrow. Right? So if you want to check the maturation of red cells, if you want to check the number of red cell, the red cell production, then you can always examine your bone marrow. Okay? So, if you want to further evaluate anemia, again, these are the following procedures, the following tests that we can use in the laboratory. Okay? So, to classify anemia, this is what we are going to use later. Kasi ito yung familiar na kayo, yung na-discuss na natin. We will further classify anemia based on the physical characteristics of the red cells. So we will check the size and the color or hemoglobin content of the RBCs. Hopefully, you can still remember it. 'Di ba? Nung nag-discuss tayo ng red cell abnormalities, we have said that there are red cells that are characterized to be microcytic and hypochromic, right? They are small and they are pale because there's less production of hemoglobin, right? If you recall it, di ba, you have their thalassemia, iron deficiency anemia, you have chronic disease, and you have sideroblastic anemia. Tama? Hopefully you remember that. So for today, pag-uusapan natin tong anemia, tong chronic disease, sideroblastic anemia, except for thalassemia. Okay? Yung thalassemia, it's a special story. It's a different story. So, we'll have it next week. Okay? Pero, when you say microcytic, hypochromic red cells, remember, they're small and pale because there's less hemoglobin. Okay? Then the other one, if you recall it, you have normocytic, normochromic RBCs. Right? They are normal in size and they do have normal hemoglobin content inside. The only problem here is the number of circulating RBCs. You suffer from anemia even if your red cells are normal in appearance, normal in morphology. You suffer from anemia because of the number of circulating RBCs. Ang konti naman ngayon ng RBC mo. Okay? In microcytic and hypochromic, okay yung production ng red cells natin. But, there's a problem with hemoglobin. This time around, there's no problem with hemoglobin content, but there's a problem in the production of RBCs. There's a problem in the number of RBCs. So, it's either you failed to produce them or you are destroying them. Hopefully, you still remember that. Diba? You have aplastic anemia, hemolytic anemia, and bleeding. No, acute bleeding. Okay? So, for our discussion about anemia, we will then discuss it based on its physical properties, physical characteristics. Kasi if you check on your books, maraming classifications ng anemia. You can also further classify them based on pathogenesis. You can classify them based on disorders of red cell formation, so meaning it's within your bone marrow. Excessive loss of red cell, meaning to say you are bleeding or you are lysing them, or there's abnormal distribution of RBCs. So, if you will check on your books, if you will check on RODAX or any other Hema books, we have different types of, or different classifications of anemia. But for these things to be a lot easier for both of us, a lot easier to understand, then we will classify them based on the physical characteristics. Okay? So to begin with, we will have microcytic hypochromic anemia. Microcytic hypochromic RBCs. And among this, the most common type of anemia of all this anemia na may encounter natin is iron deficiency anemia. So just a bit of recall so we can better understand its pathophysiology. Iron is an important component of heme. Right? So if I want to form heme, I will need iron together with protoporphyrin 9. Right? So, if I will have enough iron as well as protoporphyrin 9, I can then easily synthesize heme. And if I have heme, I can easily bind it with globin, so I can then form hemoglobin. Okay? So, to understand its pathophysiology, let's do it the other way around. Okay? If I will remove iron from the picture, kasi kulang ako ng iron, I won't be able to synthesize heme. And if I don't have heme, I don't have enough heme, I won't be able to synthesize enough hemoglobin. And without enough hemoglobin, you suffer then from anemia. And if you have anemia, there will be less distribution of oxygen onto your tissues. Okay? And iron may be deficient because of the following. O unang-una, yung pinaka-common is dietary inadequacy. One of the major sources of iron, mind you, are actually green leafy vegetables. So if you are that type of person who are not fond of eating of vegetables, then you may have problems with iron. Okay, so if you will fail to consume enough sources of iron, then there may be iron deficiency. Okay? Or let's say, sir, kain naman ako ng iron. Kain naman ako ng gulay rather. So I will have enough iron. Pero sir, meron pa rin akong IDA. So possibly, you have malabsorption syndromes. Malabsorption meaning to say, you have problems with the absorption of nutrients in your system. You have a problem with the absorption of iron in your system. Let's say. Okay? So, one more thing, mai-add ko lang. You have your, di ba? You have your parasitology class, right? Hookworms are parasitic organisms that may cause iron deficiency anemia because they compete with your body's iron. Okay? Then, increase iron loss whenever you bleed, yan, especially among women whenever you menstruate. Kaya 'di ba merong mga nagsasuffer ng anemia kapag meron na silang menstruation, or there's increased iron requirement. If there's a need for you to synthesize more red cells. Let's say kasi you're dehydrated, or let's say kasi you are moving up into a high altitude area. So that means you will need more iron so you can synthesize hemoglobin. Okay? So if you will fail to meet the iron requirements of the body, then, sad to say, you may end up with iron deficiency anemia. Okay? So laboratory-wise, sir, how do we know if there is iron deficiency anemia? Do not be confused, okay? Definitely, your iron levels are low. Definitely, that's for sure. Pero if your iron level is low, take note, it's not a confirmatory that you have iron deficiency anemia. Because, onto the next type of anemia, your iron level is also low. Okay? So, ulitin ko. If iron level is low, serum iron level is low, it does not confirm that you really have IDA. So, sir, how can I confirm iron deficiency anemia? Might as well measure ferritin. Okay? You measure ferritin. Ferritin is the stored form of iron, right? Definitely, since you lack iron, your ferritin will also be decreased, obviously. Anong i-store mo? Wala. Kasi nga, wala ka namang supplies ng iron. Okay? So again, serum iron is not a confirmation of IDA. Instead, you go with serum ferritin. Okay? So other findings will include, definitely decrease hemoglobin. You may even have a normal reticulocyte count kasi your problem naman is not with the production. Right? Your problem is with the hemoglobin content. Okay? And since your red cells are microcytic and hypochromic, you will have more pallor area. And because of this increased pallor area, your OFT becomes low. Di ba? You cannot be easily lysed kasi meron kang mas malaking pallor area. Okay? And elevated parameters will include TIBC and FEP. TIBC is total iron binding capacity. Okay? Total iron binding capacity is used so that later on, you can store iron as ferritin. So in this case, in iron deficiency anemia, wala namang paggagamitan ng TIBC. Right? Meron ba akong i-store na ferritin? Wala. That's why your TIBC will remain high. Okay? FEP is free erythrocyte protoporphyrin. If you want to create heme, ulitin natin, you will need iron together with protoporphyrin 9, right? So if I don't have iron, what happens is my protoporphyrin will just accumulate. That's why if you measure FEP, expect it to be elevated. Okay? So ulitin ko, what confirms iron deficiency anemia would be your ferritin. Okay? And then, next one here, you have anemia of chronic disease. So if you will, if you'll recall it, hopefully, natatandaan nyo pa. So, if this is my immature RBC, ito yung mga immature forms are the ones capable of creating hemoglobin, right? So, I have iron. In chronic disease, I have a lot of iron. Unlike with IDA, talagang wala kang iron. So, in this chronic disease, I have a lot of iron. The only problem is that the chronic disease I have, which could be an infection or an inflammation or cancer, this chronic disease I have blocks the delivery or entry of iron into my cell. Hindi siya makapasok. That's why this immature cell do not have iron inside. So if you don't have this iron inside, you won't be able to synthesize hemoglobin. Okay? So dito, I have a lot of iron, sir. But then, look at your values. Sir, bakit mababa pa rin yung serum iron ko? Akala ko ba ang dami kong iron? Yes, if you measure your serum iron, it's still low because those iron that you did not use will be stored as ferritin. Kaya look at your ferritin levels. Your ferritin levels are high. As compared with IDA, your ferritin level is low. Both of your iron are low, but your ferritin levels in chronic disease is high. Look at your TIBC. Sir, ang baba ng TIBC because this iron that you have in chronic disease was then stored as ferritin. That's why your total iron binding capacity also became low. Okay? So ulitin ko. To confirm IDA, do not use serum iron measurement. Might as well measure ferritin. Because both chronic disease and IDA will give you low levels of serum iron. Okay? Then, the other one is sideroblastic anemia. If you will recall it, when you say sideroblasts, it's whenever an immature cell, so this is an immature cell, contains iron deposits inside. I-connect natin yung dots. In IDA, you really don't have iron. In chronic disease, you have iron, but it was not able to enter your cell. In sideroblastic anemia, you have iron, but you have iron and it was able to enter your cell, but iron do not have that partner in life. Iron do not meet protoporphyrin 9 inside. So what happens is that iron just accumulated on your cell. So in short, what's missing here would be your protoporphyrin. Okay? Nakapasok ng lahat-lahat si iron pero still walang nangyari. And uh, if you would like to confirm if this granules inside really is iron, if you recall it, the the special stain that you need to use is what we call as Prussian blue, right? Prussian blue or your pearl stain. Okay? And with this sideroblastic anemia, it could be inherited, which is sex-linked. Very rare that it is sex-linked. Primary is a bit idiopathic, meaning the cause is still unknown. Whereas if it's secondary form of sideroblastic anemia may be associated with diseases like leukemia or disorders of hemoglobin synthesis. Let's say, kinulang ka ng B12, kinulang ka ng folic acid, you are exposed to lead poisoning, then you may have secondary sideroblastic anemia. Okay? And when it comes to your laboratory features, so look at your iron, mataas yung iron mo, mataas din yung ferritin mo. Dami mong iron, nakapasok sa cell, and at the same time, you have stored a lot of those iron. Okay? And to confirm it, again, you stain it with Prussian blue or with pearl stain. Okay? So, to compare those three, you just look at this table so you can better differentiate IDA from chronic disease and from sideroblastic anemia. Remember, in IDA, you confirm it with ferritin. Huwag niyong kalimutan yung si ferritin na yan. Okay? With TIBC, they're all different from one another. And with your iron, IDA in chronic disease will have low iron levels and sideroblastic anemia will have high iron levels. Okay? So yung isang natitira with microcytic hypochromic anemia, yung thalassemia, again, we will have it next week. Okay, so for the next part of anemia, so we'll have normocytic, normochromic anemia. So again, when you say normocytic, normochromic red cells, it's whenever red cells are normal in size, 6 to 8 micrometers in diameter with normal 1/3 pallor area. The rest is red. Tama? So the rest is filled up with hemoglobin. So, with normocytic, normochromic red cells, patients may still suffer from anemia not because of the hemoglobin content, not because of the morphologic structure of the red cells, but because of the decreased number of circulating RBCs. So if you will compare it with microcytic hypochromic earlier, your main problem there is hemoglobin, right? You failed to synthesize normal hemoglobin content on the red cells. That's why you ended up with anemia. So this time around, you have normal hemoglobin inside, you have normal morphologic features, but then the number of circulating red cells is low. That's why you still end up with anemia. Okay? So for the first example here, you have aplastic anemia. Okay? So when you say aplastic anemia, it all deals with your bone marrow. Your marrow is aplastic. There's aplasia. When you say aplastic marrow again, it's whenever there's very few or total absence of cells within the bone marrow. That's why when you have aplastic anemia, it will then be associated with pancytopenia. When you say pancytopenia, all of your blood cell counts are low. Low RBC, low WBC, and low platelets. Bakit? Because all those cells are all derived from the bone marrow, right? So it's like, if the bone marrow is totally down, there's aplasia, there's aplastic anemia, expect that all of your cell counts would be decreased. At the same time, even your reticulocyte count is low. That's why if you will further examine the bone marrow, parang makikita nyo is hypocellular yung bone marrow natin. There's very few or totally none, no hematopoietic cells within your bone marrow. Okay? And this aplastic anemia may be associated with the following. So it could be due to certain drugs like chloramphenicol and sulfonamides. So if you are taking these drugs, particularly chloramphenicol, it's an antibiotic. Hindi na yan masyadong ganong binibigay because one of its side effect is to damage your bone marrow, to affect your bone marrow. That may then lead to aplastic anemia. So sometimes it can also be true with viral infections. Yan, especially virus like parvovirus B19. Diba? That's a classic question with parvovirus B19. It's one of the most common viral organism that then results to aplastic anemia. But it could also be true with cytomegalovirus or even Epstein-Barr virus. But the most common viral infection leading to aplastic anemia is with parvovirus B19. Okay? It could be associated with exposure to certain chemicals or certain toxins, particularly benzene or herbicides, yung mga pesticides na ginagamit sa farm, or it could be due to exposure to radiation also. Radiation or through chemotherapy. 'Di ba? Kaya after radiation or chemotherapy, 'di ba, yung pasyente is like parang lantang gulay. Kasi imagine, 'di ba, chemotherapy is basically performed so we can kill cancer cells. Try to imagine if exposing my body to radiation will kill cancer cells, what more normal cells? Right? So if a patient has been exposed to radiation, he underwent chemotherapy, expect that the bone marrow will be affected, that then results to aplastic anemia. Kaya after chemotherapy, most patients will need to undergo blood transfusion para maibalik mo kung ano man yung mapalitan mo kung ano man yung nawala na mature cells sa katawan ng pasyente. Okay? And after chemotherapy, di ba, as what you see on movies, on TV series or whatsoever, di ba, lagi dapat naka-wear ng mask yung pasyente na nag-chemotherapy kasi you want to prevent any unwanted infection. Since the white cells are also down, so that person is immunocompromised. So pwede siyang dapuan ng kung anumang infection. So because the bone marrow is down and the number of white cells is down. Okay? And usually, with aplastic anemia, it could be true among people 50 years old and above. It's a case-to-case basis, by the way. Okay? Hindi porket mas bata ka, hindi ka na magkakaroon ng aplastic anemia. Mind you, we have congenital forms of aplastic anemia. The congenital form is what we call as Fanconi's anemia. Okay? Pero what I'm saying is, this aplastic anemia is quite common among individuals who are 50 years old and above. And according to statistics, people diagnosed with aplastic anemia may have 6 months mortality rate. So roughly around 50% of people diagnosed with aplastic anemia may have that 6 months mortality. Kasi imagine, down na yung system mo, no red cells will mean less oxygen delivery. No white cells or low white cells will mean infection. Less platelets will mean you bleed. Kaya if you will not be able to address properly aplastic anemia, as to studies, 50% of those individuals may have just around 6 months mortality rate. And since your problem here is your bone marrow, usually the common treatment they receive is a bone marrow transplantation. Okay? So since your bone marrow is already damaged, so you don't have any choice but then transplant a healthy set of bone marrow. Okay? And you consider aplastic anemia to be critical or to be severe if any of these values, 3 of these values are met. Okay? If you examine the bone marrow, it is markedly hypocellular. That's critical. Okay? That's severe. Imagine, sobrang baba ng neutrophils mo. Sobrang baba ng platelets mo and yung reticulocytes mo. Telling you that your entire bone marrow is totally down. And from there, complications will arise. Less oxygen, there'll be complications. Less white cells, there'll be complications like infection. Less platelets, there'll be bleeding complications, etc., etc. Okay? So, it's very important that once diagnosed na merong aplastic anemia through bone marrow examination, then you should address the problem right away by transplanting healthy sets of bone marrow. Okay? Then, next one here is pure red cell aplasia. So from the name itself, what's down are only your RBCs. So within the bone marrow, there is an absence of erythroid precursors with normal myeloid and platelet elements. Ang bagsak lang are your RBC precursors. Okay, that's why you call it pure red cell aplasia, which could be true with the following. There's hemolytic anemia, kaya naubos yung RBC precursors natin in the bone marrow. You have been infected with parvovirus, and worse comes to worse, if it's not treated right away, it may then even lead to aplastic anemia. Okay? Pero, eto, in this condition, what's down is only your red cell precursors. Okay? And the congenital form of pure red cell aplasia is what we call as Diamond-Blackfan syndrome. Okay? And then, next one, sige, tapusin lang natin hanggang hemolytic anemia, then the rest will continue it next week. Okay? So, next one would be hemolytic anemia. So, from the name itself, you are then lysing the red cells. You're then destroying the red cells. Okay? That's why there's a shortened red cell survival because of factors that resulted to the lysis or destruction of RBCs. And this hemolysis could be due to intrinsic factors or extrinsic factors. What do we mean by that, sir? When you say intrinsic factors, your problem really lies with the red cell themselves. Okay? Your red cell themselves have the abnormality, have the problem, which makes them susceptible to lysis. For example, your red cells are spherocytic. Diba? Pag spherocytic yung RBC natin, ibig sabihin, you don't have that enough pallor area. So meaning to say, your red cells are susceptible to lysis. So if the problem lies within the red cell itself, then you call it as intrinsic hemolytic anemia. Okay? Then when you say extrinsic, sir, my red cells are healthy. My red cells are normal. But when you say extrinsic, there are external factors, external forces that destroyed your RBCs. For example of which, Plasmodium falciparum. Diba? Once that parasite enters your body, it will then damage and affect your RBCs. So that could be extrinsic hemolytic anemia. Okay? So, this lysis, whether it's intrinsic or extrinsic, may occur either intravascular or extravascularly. So, intravascular, obviously, red cells are lysed while they are inside the blood vessels, and extravascular means red cells are lysed outside your blood vessels. Okay? So, unahin natin si intrinsic hemolytic anemia. So, with intrinsic hemolytic anemia, there could be hereditary defects like abnormalities of the red cell membrane, just like with spherocytosis and elliptocytosis. Please go back doon sa discussion natin sa spherocytes, sa elliptocytes, di ba? In spherocytes, your problem there is spectrin, right? In elliptocytosis, your problem there is protein band 4.1, which makes them susceptible to lysis, right? With inherited enzyme defect, so from the name itself, there are certain enzyme deficiencies within your red cells which makes them susceptible to lysis. And then this one here, with hemoglobin production problem, we will deal with that next week. Isasabay natin sa thalassemia. Okay? Kasi you call it as hemoglobinopathies, which is aligned with the discussion of thalassemia. Okay? So, ang focus muna natin with these hereditary defects would be your red cell membrane abnormalities and your enzyme defects. Okay? And then with acquired defects, what we have here with hemolytic anemia would be the so-called paroxysmal nocturnal hemoglobinuria. Later, we have it. Okay? Paroxysmal nocturnal hemoglobinuria. Okay? So, unahin natin si hereditary spherocytosis. So, with hereditary spherocytosis, it's an autosomal dominant trait in common among whites, and it is caused because of a deficiency in spectrin. If you'll recall it, there's a deficiency in spectrin or there's thermal injury. Red cells were exposed to increased temperature. That's why they have lost their pallor area. They have decreased surface area to volume ratio, which makes them susceptible to lysis. And when it comes to testing, remember, what we use here is osmotic fragility tests. Okay, that's one of the most important procedure that will further help us diagnose hereditary spherocytosis. So, since cells are less deformable, it makes their OFT values elevated. Okay? So, people with hereditary spherocytosis, and sige, ganito, para hindi tayo paulit-ulit. Okay? So, since we're talking about hemolytic anemia, remember, if red cells are lysed, all of its contents will come out. Okay? All of its contents will come out like enzymes, or let's say LDH, potassium will come out, and so on and so forth. So expect that if you will measure them in the blood, expect them to be elevated as long as it's hemolytic anemia. Okay? Mataas si LDH, mataas or tataas si potassium levels natin, and so on and so forth. All contents of red cells will come out. And if you want to further assess bone marrow's response in cases of hemolytic anemia, remember, the best procedure to check on that one is counting reticulocytes. Okay? So, counting reticulocytes will then further help us identify whether our bone marrow is responding well or not in cases of anemia, particularly hemolytic anemia. Okay? So again, you have here hereditary spherocytosis, and this would be the following features. So going back, so this would be the clinical features of hereditary spherocytosis. So expect that there's jaundice kasi those and then expect that your OFT level is high, and take note of this. If OFT level is high, it could mean hereditary spherocytosis, or it could mean presence of autoimmune hemolytic anemia. Okay? Autoimmune hemolytic anemia. So, if you want to be sure if it's hereditary spherocytosis or autoimmune hemolytic anemia, you can then perform Coombs test. Ayan, kung nadaanan nyo na sa blood bank nyo. So, if you will then perform Coombs test and it happens to be positive, you then associate that with autoimmune hemolytic anemia. When you say autoimmune hemolytic anemia, you are destroying your own red cell. Okay, that's why you call it autoimmune. Okay, so if that OFT is elevated, yes, most likely it suggests hereditary spherocytosis, but it may also then deal with autoimmune hemolytic anemia. So if you want to be sure about that, you can go with with Coombs tests. Okay? So, moving on, you have hereditary elliptocytosis. So again, so you have here a deficiency with protein band 4.1, which makes the red cell susceptible to lysis. Okay? So ang i-highlight natin with this intrinsic hemolytic anemia would be your enzyme defects, particularly G6PD deficiency. Kasi as what you've learned, G6PD is a very important enzyme so that later on, you can prevent oxidative stress among your red cells. Right? Which is, this one is involved in your pentose phosphate pathway, right? Hexose monophosphate shunt. That will later on provide you glutathione to make sure that you can then prevent oxidative stress on your red cells. Right? So if you will have deficiencies with G6PD, expect that you will have problems with oxidative stress. And whenever your red cells are exposed to oxidative stress, hemoglobin later on will be denatured. If hemoglobin is denatured, then it then loses their ability to later on carry and deliver oxygen. This is actually the most common enzyme deficiency affecting hematopoietic cells. And technically speaking, aging cells or yung mga old cells natin are more susceptible to destruction, are more susceptible to oxidative stress. So what more if you have G6PD deficiency? Okay, so again, it's the inability to neutralize oxidation stress because reducing NADPH or glutathione is not formed. And if you recall it, those denatured hemoglobin will then be manifested on your red cell cytoplasm and you call it as Heinz bodies. Right? And Heinz bodies are further evaluated with the use of supravital stain. Tama? So for G6PD deficiency, you may then expect jaundice. It could be associated with drug-induced hemolysis, particularly if you are taking Primaquine. Primaquine, which is used for malaria, right? And it could also be true with Favisim. Favisim is a Mediterranean enzyme variant. So Favisim is called as such whenever you consume fava beans. Okay, so this fava beans results to oxidative stress. Kaya nagre-result na ng lysis doon sa pasyente natin. So if you have G6PD deficiency and you have consumed fava beans, it will then lead to lysis. And if there's one good thing about G6PD deficiency is that you are then protected against plasmodium infections. So parang you are resistant with plasmodium infection, particularly with falciparum. So you may confer resistance with malaria. Yun lang yung maganda sa kanya, but other than that, definitely G6PD deficiency is not ideal. Okay? Yes, you may confer resistance to malaria, but complications will arise because of red cells destruction. Okay? And we have three major classes of G6PD deficiency. So you have class 1, 2, and 3. So if you recall it on your enzymology class, if you will be measuring enzymes in the laboratory, you measure their activity and not their absolute values. Hopefully, you can recall that. And hopefully, that's clear with you. In enzymology, if you are measuring enzymes, remember, what you are measuring is their activity and not their values. Not their absolute values. Okay? So with class 1 and class 2, both of them are characterized to have less than 10% activity of G6PD. The difference is, in class 1, your hemolysis is chronic, and in class 2, your hemolysis is intermittent. Intermittent meaning pabalik-balik. Mawawala, tas babalik. Okay? And with class 3, your enzyme activity is roughly around 10 to 60%. So still it's deficient, right? And if it's class 3 or the mild deficiency, hemolysis will only occur, will only happen if there are stressors. If there are factors that causes oxidative stress on your RBCs. Okay? So laboratory-wise, again, one of the most important confirmatory procedure for G6PD deficiency is checking your Heinz bodies. Tama? So, with the use of supravital stain. So, there could be increased reticulocytes, as what we've said, because the bone marrow is responding. Bilirubin will be elevated as well as with LDH, and hemoglobin may also be present on your urine. Okay? So, what's decreases aptoglobin? Kasi intravascular, whenever red cells are lysed, di ba, intravascularly, lalabas si hemoglobin, and hemoglobin will later on bind with haptoglobin and will then be phagocytized by WBCs. Okay? Then, confirmatory test definitely would be G6PD assay. And with G6PD assay, you're after with fluorescent testing. Okay? Fluorescence testing yung ginagamit natin. So, if there will be fluorescence on your red cells, then that means meron kang G6PD. Pag walang nag-fluoresce, or konting-konti lang yung nag-fluoresce on your red cells, then that may indicate deficient G6PD activity. Okay? And then another one, sige, dagdag nyo na lang sa notes nyo, you can also have their ascorbate cyanide tests, which is non-specific naman for G6PD deficiency, wherein you make use of sodium cyanide and sodium ascorbate, yung vitamin C natin. And what's normal here is that your solution will remain red. Meaning to say, your red cells were not lysed. It's like, this two here serves as your stressors. Okay? So, pag red pa rin yung solution nyo, that means your red cells were not lysed. But if your solution turns brown, that means that your red cells were lysed because of these stressors. Okay? Then lastly, for this enzyme deficiency, you have pyruvate kinase deficiency. And your main problem here deals with Embden-Merov pathway. Since pyruvate kinase is an essential enzyme for the production of ATP, for the production of energy. Right? So it's an autosomal recessive disease, and its effects, deficiencies with pyruvate kinase, its effects is more profound among older RBCs. Okay, so mas nakikita sa mga matatanda na red cells. Kasi as red cells age, their metabolism slows down. Okay? So with this failure to generate sufficient ATP, it will then further allow, kunyari ito yung RBC natin, because of the less ATP you have, it will further allow sodium as well as calcium to enter your cell. And as this sodium and calcium enters your cell, the more it then results to damage or lysis. Okay? And as you see, pag merong hemolytic anemia or merong hemolysis, as you see, laging merong lumalaki yung liver, lumalaki yung spleen rather, and nagkakaroon ng jaundice. Bakit, sir? Kasi those byproducts that you form will be eliminated by the spleen. And if red cells are lysed, especially extravascularly, you will form more and more bilirubin. That's why nagkakaroon ka ng jaundice. Okay? And then lastly, the acquired defect causing hemolytic anemia is what we call as paroxysmal nocturnal hemoglobinuria. Okay? So it's a rare acquired disorder characterized by the proliferation of abnormal clones of hematopoietic cells within the bone marrow which may be manifested by hemosiderin in your urine, after a night's sleep. So you may have presence of hemosiderin granules or hemoglobin granules on your urine after a night's sleep. Okay? So, to make it a bit more simple, in paroxysmal nocturnal hemoglobinuria, your red cells are lysed because of increased susceptibility with complement. Remember, complement is a protein that will then, once activated, will then result to lysis. Right? Normally, an active complement will not lyse your RBCs. Tama? So the problem with paroxysmal nocturnal hemoglobinuria is that complement will then easily lyse your RBCs. Bakit, sir? Because within your red cell, there is a deficiency in an important component called DAF. Ano yung DAF, sir? DAF is decay accelerating factor. There's a deficiency in DAF on your red cells membrane that then results to complement lysis on your red cells. Kasi this DAF here regulates your complement system. So kahit active yung complement na yan, it will not lyse your red cells because you have DAF. But in paroxysmal nocturnal hemoglobinuria, you have deficiencies in DAF. That's why your red cells then can be easily lysed by the complement. Okay? So also, in paroxysmal nocturnal hemoglobinuria, there may be deficient acetylcholinesterase activity and abnormally constituted glycoproteins within your cell membrane. Excuse me. Within your cell membrane that then results to increased susceptibility to lysis by complement. Okay? So, for the laboratory diagnosis of paroxysmal nocturnal hemoglobinuria, we have the following here. So we have sugar of sucrose lysis test. So what you have here would be patient's red cell plus an ABO, take note, ABO compatible serum. So if patient is type A, yung serum na to will also be from a type A person. Okay? Sir, para saan yung serum na yan? Your serum will be the source of your complement. Okay? So you have your patient's red cells mixed with serum, mixed with sucrose. Okay? So, if you observe lysis, that then gives you an idea that your patient has paroxysmal nocturnal hemoglobinuria. Kasi if this is ABO compatible, that means it's not in any way related to antibodies. Right? Kasi nga, compatible naman silang dalawa. So, bakit malalays yung red cell? So, that tells us an idea that it might be because of complement. Okay? So, if you want to confirm if it's really because of complement, you go with Ham's acidified serum test or Ham's acid serum test or Ham's acid hemolysis test. So what you do here is, you have three different setups here. So you have your patient's red cell mixed with a normal serum. Still, ano yan ABO compatible serum, okay? Plus 0.2 normal hydrochloric acid. Okay? Weak acid that will then facilitate lysis. Okay? Another one is your patient's red cells plus own serum. Sir, bakit natin gagamitan ng own serum? So that you can rule out autoimmune disease. Autoimmune hemolytic anemia. Okay? So you can rule that one out. Kasi there are times na your red cells are lysed because you produce an antibody against your own red cell. Okay, there are those cases. Then the third one is your patient's RBC plus an inactivated serum. When you say inactive serum, that means wala siyang lamang complement. Right? So if you will heat your serum at 56 degrees Celsius, you may then inactivate your complement. Okay? Plus your acid. Your 0.2 normal hydrochloric acid. Okay? So, what's normal is, if the patient is negative for paroxysmal nocturnal hemoglobinuria, normal is, there'll be no hemolysis in all these three. Sa tatlo na yan, walang hemolysis. But if your patient has paroxysmal nocturnal hemoglobinuria, there will be hemolysis on tube 1, hemolysis on tube 2, but no hemolysis in tube 3. That tells you that your patient really has paroxysmal nocturnal hemoglobinuria. Sir, bakit walang hemolysis doon sa pangatlo? Because your serum is inactive. Right? So if it's inactive, that means it doesn't contain complement. Okay? So if all of these three tubes will show no hemolysis, then you say it's normal. But if the first two tubes shows you hemolysis, then that may then, and the third one did not, that may then indicate na your patient really has paroxysmal nocturnal hemoglobinuria. Okay? And then, ito, ihabol lang natin ng konti, yung extrinsic hemolytic anemia. So with extrinsic hemolytic anemia, as what we said earlier, red cells are lysed because of external factors. Red cells, technically speaking, are healthy. It's just that there are external factors that cause lysis on your RBCs. Right? Unlike the intrinsic. Sa intrinsic, yung red cell mismo is abnormal. That's why they are susceptible to lysis, right? But with extrinsic, technically speaking, red cells are healthy. It's just that there are external factors that destroyed your RBCs. And these external factors could be non-immune or immune. Okay? When you say immune, it has something to do with antibodies. Remember, red cells contain antigen on its cell surface, right? On its cell membrane. So if there is an antibody against that antigen, there will be lysis, right? So when you say non-immune, it has nothing to do with immune activities. It has nothing to do with antibody or antigen activity. Okay? So and when you say immune, it could be autoimmune or allo. When you say auto, you produce an antibody against your own. Okay? Allo, the antibody destroying your own, destroying your antigen was from another individual. Was from another different person. Kaya usually, yung allo antibody na yan, alloimmune hemolytic anemia, could be due to incorrect transfusion of blood. Let's say type A si patient, pero ang nasalin mo na blood is type B, then expect that the antibody of the donor's blood may then destroy your antigen. Okay? So, sige, tapusin lang natin yung immune and non-immune. Then we'll stop there, then we'll continue next week. Okay? So with immune hemolytic anemia, first we have here autoimmune hemolytic anemia, which is associated with cold antibodies. If it's cold antibody, you are referring to IgM. Tama? Kasi IgM are your cold reacting antibodies. Tama? So these antibodies react best at temperature below 32 degrees Celsius and may occur in association with infection. It may also occur in association with malignancy or any autoimmune disorders. Okay? So, to confirm that you really have autoimmune hemolytic anemia, you can then perform Coombs test, yung binanggit ko sa inyo kanina. Coombs test or your direct antiglobulin test. If it's positive, then you have autoimmune hemolytic anemia. And your cold agglutinins may also be elevated. Okay? And the antibodies associated here with autoimmune hemolytic anemia due to cold antibodies could be with anti-I, capital letter I, and anti-small letter I. Okay, so these are your cold agglutinins. Okay, agglutinins refers to antibody, right? So this anti-capital I here is the one associated with infections with Mycoplasma pneumoniae. Okay? Mycoplasma pneumoniae, yung the one causing primary atypical pneumonia. So if you have been infected with Mycoplasma pneumoniae, you may develop anti-capital I that may later on affect your RBCs. Okay? Whereas this anti-small letter I have been associated with infections with infectious mononucleosis. The ones caused by Epstein-Barr. Right? So, if you had infectious mononucleosis, you may then develop anti-small letter I that may then damage your RBCs. Okay? So, with this one, these cold antibodies are the ones that will lead to the lysis of your RBCs. Okay? And then the other one, with warm autoimmune hemolytic anemia, obviously, it's with warm antibody, and that warm antibody refers to IgG. Right? So, RBCs will react with IgG and or with complement that then leads to hemolysis. Okay? So, secondary usually is caused by lymphoma or caused by leukemia. And to make sure that it's really an autoimmune hemolytic anemia, remember, you always use that direct antiglobulin test. So, you can further differentiate autoimmune hemolytic anemia from hereditary spherocytosis. Okay? Kasi both of them, mataas ang OFT, right? So, for warm autoimmune hemolytic anemia, we have this thing called paroxysmal cold hemoglobinuria. Please do not be confused, okay? You call it cold hemoglobinuria because there's a reason for that, okay? But the antibody associated here still is IgG. Okay? IgG. That's why it's still with warm autoimmune hemolytic anemia. So, sir, why do we call it paroxysmal cold hemoglobinuria? So, this anemia is caused by the presence of an autohemolysin, your antibody, in the plasma that becomes attached to the red cells while in a cold environment. So, if this is my red cell, and you have been exposed to a cold environment, yung red cells natin nasa cold temperature, this antibody, yung IgG na yan, will bind on your red cells. Okay? Nasira na ba yung red cell, sir, ko? Hindi pa. Nakadikit pa lang si autohemolysin. Okay? And when red cells are warmed, ininit mo na uli yung red cell, this antibody attaches on your RBCs. And once you place it in a warm environment again, doon na magkakaroon ng lysis. Because IgG here will react best at warm temperature. Tama? And this antibody associated with paroxysmal cold hemoglobinuria is what we call as anti-P, capital P, okay? Anti-P or what we call as Donat-Landsteiner antibody. Again, anti-P or Donat-Landsteiner antibody is an IgG antibody which fixes the complement to RBCs in cold environment, and it will be lysed when placed in warm temperature in 37 degrees Celsius. Okay? And then for alloimmune hemolytic anemia, again, you have here blood transfusion. So it could be because of patient has antibodies against the antigen from the blood donor or the other way around. Okay, so you may you may have here a positive DAD, elevation of hemoglobin, presence of antibodies, IgM antibodies, which could be due to ABO incompatibility or RH incompatibility. Okay? And then last one, you have here your non-immune. So non-immune, it has nothing to do with it has nothing to do with antibody or antigen activities. Okay? So example of which could be transient forceful contact of the body with hard surfaces. Ayan, kapag merong external pressure or external trauma that then affected your blood vessels resulting to the damage on your RBCs. Sometimes this transient non-immune hemolytic anemia may be due to example, yung mga marathon runners, yung mga triathletes. So because of the excessive usage of the muscles, there will be tear on the muscles, there will be tear on their tissues that will then affect the blood vessels resulting to the damage on RBCs. No, even mga tennis players, yung mga boxers, ayan, sa mga boxers sa kada suntok, kada movement ng muscle nila, then red cells may be injured. Red cells may be lysed. Okay? Even dun sa sa mga how do you call it? Yung sa Bataan March, yung mga nagmarcha mula Bataan. So possibly because of the excessive use of their tissues and of their muscles, some of them have died probably because of hemolytic anemia. Nasira yung cells. Okay, so it could also be because of mechanical trauma like certain chemicals, drugs, or snake venom, or prosthetic heart valves. Nakakasira yun ng RBC. Yung mga naoperahan sa puso na nilalagyan ng mga parang stent on their vessels para dumali uli yung blood. So, one of its side effect is damaging the RBCs. And these prosthetic heart valves causing non-immune hemolytic anemia is referred to as wearing blender syndrome. Yan, pag nasira na yung RBCs because of prosthetic heart valves. Okay? So, it could also be because of burns. Yan, pag nagkaroon ka ng severe burns, third-degree burns specifically. So, infections which damages the red cells membrane like Plasmodium falciparum or Clostridium perfringens that then leads to the hemolysis on your RBCs. Okay? And hopefully, you still remember this. Microangiopathic hemolytic anemia, which causes the formation of schistocytes. Right? Diba, in microangiopathic hemolytic anemia, if there are unwanted clots or unwanted products on the walls of your vessels, red cells will then pass on through those area, resulting to lysis. Example of that would be DIC, disseminated intravascular coagulopathy. Within your blood vessels, you are forming unwanted clots. You have activated your coagulation mechanism unwantedly. Wala ka namang injury pero na-activate mo yung coagulation mechanism. That's why you have formed clots within your blood vessel wall. So if red cells will pass on through those clots, red cells will be lysed. Okay? Red cells will be damaged. Similar with the other two, hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. So with HUS, you have their lysis of red cells, particularly on your kidneys. And with thrombotic thrombocytopenic purpura, it could be in any parts of your body. Na nangyayari sa TTP is you also break down your von Willebrand factor. Then as you break down your von Willebrand factor, then it then leads to increased destruction on your blood vessels, resulting to clot formation. That's why red cells passing on through those clots will then be lysed or will then be destroyed. Okay, so do not forget that. Yung microangiopathic hemolytic anemia. So as long as you have any unwanted materials within the walls of your vessels, particularly clots, then you expect that red cells will be lysed. Okay? So,
okay, sige. So for those questions, ayan, meron tanong dito. Do we consider stem cell therapy in cases of aplastic anemia? Definitely. Okay, it's one of the recent advances that we use in managing different diseases, and that will include aplastic anemia. Okay? Then, ABO compatible serum. When you say ABO compatible serum, again, as what I have given on your example a while ago, if patient is type A, the serum compatible to that patient is the serum of a person with type A blood also. Tama? Kaya nga tinawag na compatible. Kung type A si patient, dapat yung donor, yung serum na gagamitin mo, is also type A. That's why you call it as compatible. AA lang siya. Or let's say BB, OO, or kaya ABAB. Okay? Kasali po ba yung MCH sa pag-differentiate ng anemia? In essence, yan, if you will recall it from our previous discussions, do we use MCH, sir, in classifying anemia? Theoretically, possible. You can use that. But practically, we don't utilize MCH because we rely more with MCHC. O if I ask you, why do we prefer MCHC compared with MCH? Ano uli yung reason? Anyone? Ano uli yung reason?
Kasi po,
Why do we go with MCHC?
po yung measure.
Kasi in MCHC, you're actually measuring the actual concentration of hemoglobin. Kapag MCH, di ba ang problema natin doon, it's more of the weight. Right? It's just a weight. So MCHC is, let's say, more specific and more sensitive when it comes to identifying hemoglobin abnormalities on your red cell, hemoglobin concentration deficiency on your red cell. Unlike with MCH. Kasi sa MCH, it's weight lang. And that weight could be affected by different factors present within your RBCs. Okay? Then, next week, we will continue with bleeding. And then what we will highlight next week would be thalassemia. So we'll further deal with globin abnormalities as well as hemoglobinopathies. Yan, whenever you have hemoglobin S, yung mga nabanggit na natin back then, hemoglobin S, hemoglobin C, hemoglobin SC, and so on and so forth. So that would be our main concern next week. Okay, so for your quiz this coming Monday, it will only be up to our topic today. Okay, hanggang ano lang tayo, hanggang hemolytic anemia. So from IDA hanggang hemolytic anemia, extrinsic and intrinsic hemolytic anemia. Okay? Then later, for your laboratory class, let's meet siguro mga ano na lang, 5:30 p.m. We'll meet at 5:30 p.m. Okay? Sige,
Okay, sir.
any questions? Any other concerns?